If you've ever been told you have high blood pressure, the advice probably came fast and automatic. Cut out the salt. It sounds simple, it sounds logical, and it sounds like something you can fix immediately. But here's the uncomfortable truth. For millions of people, that advice is incomplete, and in many cases, it sends them in the wrong direction. Not because salt doesn't matter, it does, but because salt is only one small piece of a much bigger biological system. And when you focus on sodium alone, you miss the real drivers of why blood pressure went up in the first place. That's why so many people cut salt aggressively, follow the advice perfectly, and still end up on lifelong medication. In this video, we're going to break that cycle. I'll walk you through the real, often overlooked causes of high blood pressure, rooted in human physiology, not headlines. And once you understand these mechanisms, you'll see why blood pressure often improves quickly when the right levers are pulled, sometimes even before medications are needed. Let's start with why salt became public enemy number one. The logic goes like this. Sodium pulls water into the bloodstream. More water increases blood volume. Higher blood volume raises pressure inside the arteries. That part is biologically correct. But what almost never gets explained is what happens next in a healthy body. So your kidneys are not passive filters. They are active pressure regulators. The moment blood pressure rises, healthy kidneys sense the increase, excrete excess sodium, release excess water through urine, and bring blood pressure back down. This feedback system is extraordinarily efficient, which is why some people eat salty foods with no issue. Others see dramatic pressure spikes from the same intake. This is known as salt sensitivity, and it varies widely between individuals. So here's the key insight. If blood pressure stays high even after sodium is reduced, sodium is not the primary problem. The real problem is how the body is handling sodium, not how much is consumed. And this is where most conventional advice stops. Far too early. Blood pressure is not controlled by one switch. It's regulated by a complex network involving kidneys, blood vessels, hormones, nervous system, minerals, metabolism. When one piece fails, the others compensate. And when several fail at once, pressure rises chronically. This is why treating blood pressure like a single dietary mistake misses the real cause. High blood pressure usually develops because of mineral imbalances, metabolic dysfunction, hormonal signaling errors, chronic nervous system activation. Salt only becomes dangerous when these systems are already broken. So let's start unpacking what actually breaks first. One of the most overlooked drivers of high blood pressure is magnesium deficiency. Magnesium is not optional. It's essential for blood vessel relaxation, nitric oxide production, normal vascular tone. Magnesium supports two critical molecules: nitric oxide, which widens blood vessels, prostacyclin, which prevents excessive constriction when magnesium levels are low. Blood vessels stay tighter than they should. Resistance increases, pressure rises. This happens independently of salt intake. And here's why this matters so much. Low magnesium is extremely common. Modern diets are dominated by refined grains, added sugars, ultra-processed foods. These foods contain very little magnesium, actively increase magnesium loss through urine. Even worse, modern agriculture has depleted soil minerals, meaning the same foods contain less magnesium than they did decades ago, so even people eating reasonably well may still be deficient. Clinical research consistently shows lower magnesium levels are associated with higher blood pressure. Supplementation produces measurable reductions in both systolic and diastolic pressure. Effects are stronger in people already diagnosed with hypertension. This is not alternative medicine. This is basic vascular biology, and yet magnesium is rarely addressed early. Now let's talk about insulin, one of the most underappreciated blood pressure hormones. When insulin levels are chronically elevated, the kidneys begin retaining sodium. Sodium retention pulls water with it. Blood volume increases. Blood pressure rises. This happens even if sodium intake stays the same. That's why high blood pressure is so common in insulin resistance, prediabetes, type 2 diabetes, and it explains something many people notice. Blood pressure often improves before significant weight loss occurs because insulin levels drop first. This is why reducing refined carbohydrates, added sugars, processed foods often lowers blood pressure more effectively than salt restriction alone. Salt raises pressure temporarily. High insulin locks it in chronically. Fructose deserves special attention. Fructose is a sugar commonly added to sweetened drinks, packaged foods, preserved snacks. When consumed in excess, it increases uric acid production. Uric acid blocks nitric oxide. Blood vessels become stiffer. Kidneys struggle to excrete sodium. This creates a perfect storm. Vascular constriction, sodium retention, rising blood pressure. Many people associate uric acid only with gout, but elevated uric acid is increasingly recognized as a causal factor in hypertension. Lowering fructose intake alone has been shown to reduce uric acid, improve vascular function, normalize blood pressure in susceptible individuals. This is why dietary changes often outperform medication in early-stage hypertension. Potassium is sodium's physiological counterweight. It works in three major ways. In blood vessels, promotes relaxation, reduces resistance. In the kidneys, signals sodium excretion, lowers blood volume. In the brain, reduces sympathetic nervous system activity, calms the fight-or-flight response. Modern diets are extremely high in sodium, critically low in potassium. This imbalance alone can elevate blood pressure, even if sodium intake doesn't appear excessive. The potassium-rich foods include root vegetables, leafy greens, legumes, vine fruits. These foods often also supply magnesium, fiber, and metabolic support, compounding their benefit. High blood pressure rarely starts as a single mistake. It develops when mineral deficiencies persist, insulin remains elevated, uric acid accumulates, nervous system stays overactive. Over time, blood vessels stiffen, elasticity is lost, pressure becomes harder to reverse. This is the point where medication becomes necessary. Not because lifestyle failed, but because intervention came too late. The goal is not to reject medication. The goal is to address root causes early while reversal is still possible. We have exposed a major myth that high blood pressure is simply the result of eating too much salt. But what we actually uncovered was something far more important. Salt only becomes dangerous when the body loses its ability to regulate it. And one of the fastest ways that regulation breaks down is through mineral deficiencies. In this video, we're going to focus on two minerals that quietly control blood pressure every second of your life: magnesium and potassium. These are not supplements trends. They are not optional nutrients. They are core regulators of blood vessel tone, kidney sodium handling nervous system activity. And when they're low, blood pressure rises even on a low-salt diet. Here's an uncomfortable reality of modern medicine. Most blood pressure evaluations focus on the pressure number, the medication choice. Very few focus on intracellular mineral status, Long-term dietary mineral depletion, kidney vascular signaling errors. Why? Because mineral deficiencies develop slowly, don't show up clearly on standard labs, and don't fit into a prescription model. But physiology doesn't care about convenience. Blood vessels cannot relax, kidneys cannot excrete sodium, and nerves cannot calm down without adequate minerals. Magnesium is one of the most critical and most ignored blood pressure regulators. It influences blood pressure through four major mechanisms. Your blood vessels are lined with smooth muscle cells. Magnesium acts as a natural calcium antagonist, prevents excessive contraction, allows vessels to widen when needed. When magnesium is low, calcium floods into these cells. Vessels constrict, resistance rises, blood pressure increases. This happens regardless of salt intake. Nitric oxide is the molecule that tells blood vessels to relax. The magnesium enhances nitric oxide synthesis, protects nitric oxide from breakdown. Low magnesium equals reduced nitric oxide, stiffer arteries, higher systolic pressure. This relationship is repeatedly confirmed in vascular research published in journals such as Hypertension in Circulation. Remember insulin from part 1? Magnesium improves insulin receptor signaling, reduces compensatory insulin spikes. Low magnesium worsens insulin resistance, which increases sodium retention, raises blood volume, elevates blood pressure. This explains why magnesium deficiency is so common in prediabetes, type 2 diabetes, metabolic syndrome. Magnesium suppresses excessive sympathetic activity, the fight-or-flight system. Low magnesium keeps the body in a stress state with elevated adrenaline and chronically raised blood pressure. This is why magnesium deficiency is often linked to anxiety, poor sleep, resistant hypertension. Here's a shocking part. Large dietary surveys suggest nearly half of adults fail to meet recommended magnesium intake, and that's likely an underestimate. Why? Because refined grains remove magnesium, sugar increases magnesium loss through urine, alcohol depletes magnesium, chronic stress burns through magnesium rapidly. Even normal blood magnesium levels can be misleading because less than 1% of magnesium is in the blood. Most is stored inside cells and bone, so deficiency can exist long before labs flag it. The clinical trials compiled in meta-analyses published through the American Journal of Clinical Nutrition consistently show magnesium supplementation lowers systolic and diastolic blood pressure. Effects are strongest in people with hypertension. Benefits appear within weeks, not years. If magnesium relaxes vessels, potassium controls sodium. Potassium is sodium's biological counterweight, and modern diets are dangerously unbalanced. High potassium signals the kidneys to excrete excess sodium, reduce fluid retention. Lower blood volume, low potassium tells the kidneys the opposite. Hold sodium, hold water, increase pressure. This occurs even if sodium intake is moderate. Potassium hyperpolarizes vascular smooth muscle, reduces contraction, improves arterial compliance. Low potassium increases vascular stiffness, raises systolic pressure. Potassium lowers sympathetic nervous system output. And that means less adrenaline, less renin release, less angiotensin signaling. In simple terms, potassium turns down the blood pressure thermostat. Our ancestors consumed high potassium, low sodium. Modern diets flip that ratio. So ultra-processed foods strip potassium, add sodium. This imbalance alone has been associated with higher stroke risk, higher cardiovascular mortality, poor blood pressure control, Large population studies reported in BMJ demonstrate that higher potassium intake correlates with lower blood pressure. Benefits occur even without sodium restriction. The most effective way to restore minerals is food first. Magnesium-rich foods, leafy greens, legumes, nuts and seeds, dairy potassium-rich foods, potatoes and sweet potatoes, tomatoes and tomato products, beans and lentils, spinach and leafy greens. Notice something important. Many of these foods provide both minerals simultaneously. This synergy is why whole foods outperform isolated strategies. In some cases, diet alone isn't enough. This includes people with long-standing hypertension, insulin resistance, diuretic use, chronic stress or poor sleep. Clinical trials suggest magnesium doses around 300 to 400 milligrams per day show consistent blood pressure benefit. Potassium supplementation, however, must be individualized, requires kidney function awareness, should often focus on diet first, always discuss supplementation with a healthcare provider, especially if you're on blood pressure medication. Here's why people are often shocked by how fast their numbers improve. Minerals act on vessel tone, kidney sodium handling, nervous system output. These systems respond within days to weeks. You're not reversing decades of plaque overnight. You're restoring regulation. And that's why blood pressure drops before weight loss. Improvements occur without medication changes. The body remembers how to self-regulate. If this video helped you understand your blood pressure in a new way, subscribe and stay with the series. Because once mineral balance is restored, we can finally address the metabolic drivers that keep blood pressure high. By now, one thing should be clear. High blood pressure is not just a heart problem. It's not just a kidney problem. And it's definitely not just a salt problem. It is very often a metabolic problem. In this video, we're going to uncover one of the most ignored truths in medicine. Many cases of high blood pressure are driven by insulin, sugar, and uric acid, not sodium. This is why blood pressure so often improves. Before weight loss, before medications are increased, and sometimes before people even understand why it worked. Once you see these mechanisms clearly, the pattern becomes impossible to ignore. Most people think of insulin as a blood sugar hormone. That's only half the story. Insulin is also a powerful kidney hormone. When insulin levels are elevated, the kidneys retain sodium. Sodium pulls water with it. Blood volume increases, blood pressure rises, and this happens even if sodium intake stays exactly the same. This is one of the strongest links between insulin resistance, prediabetes, type 2 diabetes, and hypertension. This mechanism has been described repeatedly in nephrology and cardiovascular research published in journals like Journal of the American Society of Nephrology. So when someone has chronically high insulin, cutting salt helps only marginally because insulin is telling the kidneys to hold on to it. That's why high blood pressure is so common in metabolic disease. This explains something many people find confusing. They change their diet. They haven't lost much weight yet, but their blood pressure starts dropping. Why? Because insulin levels fall first. Weight loss is a downstream effect. Insulin reduction is the upstream signal. When insulin drops, kidneys release sodium. Excess water is excreted. Blood volume falls. Pressure decreases. This is why low refined carbohydrate diets, reduce sugar intake, whole food metabolic resets often outperform low salt diets for blood pressure control. Not all sugars affect blood pressure equally. Fructose is uniquely harmful. Unlike glucose, fructose is processed almost entirely in the liver. It rapidly increases uric acid production And uric acid is not innocent. Elevated uric acid blocks nitric oxide, stiffens blood vessels, impairs kidney sodium excretion. This directly raises blood pressure. Large observational and experimental studies published in Circulation show higher uric acid levels predict hypertension, especially in younger adults and early disease. This is why sugary drinks are so strongly associated with early onset hypertension, metabolic syndrome, fatty liver disease. Most people only hear about uric acid in the context of gout, but uric acid plays a much bigger role in vascular health. The high uric acid reduces nitric oxide availability, increases oxidative stress, promotes vascular stiffness, activates the renin-angiotensin system. In plain terms, it makes blood vessels tighter and kidneys hold salt. In fact, uric acid is now recognized as a causal contributor to hypertension, not just an association. This shift is discussed extensively in reviews published in Hypertension. Here's a critical connection. Fructose doesn't just raise uric acid, and it also makes kidneys more salt-sensitive, reduces sodium excretion, amplifies blood pressure response to salt. So in someone consuming sugary drinks, processed foods, high fructose sweeteners, salt becomes far more damaging. This is why cutting sugar lowers blood pressure. Even if salt intake stays moderate, it's not the salt. It's the metabolic context the salt is entering. In clinical practice, a common pattern emerges: patients with elevated insulin, high triglycerides, fatty liver, elevated uric acid almost always struggle with blood pressure control. And when those metabolic markers improve, blood pressure often normalizes, medication requirements drop, variability stabilizes. This isn't anecdotal, it's metabolic physiology. The most effective blood pressure strategies target insulin and uric acid directly. That means reducing added sugars, eliminating sugary drinks, minimizing ultra-processed foods, prioritizing whole carbohydrates with fiber. This approach lowers insulin, reduces uric acid, improves kidney sodium handling, restores vascular relaxation, and importantly, it works without extreme salt restriction. In some cases, diet alone isn't enough, especially when uric acid is significantly elevated. Blood pressure remains resistant. Medications that lower uric acid, such as allopurinol, have been shown to improve endothelial function, reduce blood pressure, especially in younger and metabolically driven hypertension. This is discussed in controlled trials summarized in the New England Journal of Medicine. The key point: treatment works best when the true driver is identified. A metabolic hypertension is different from structural hypertension. Before arteries become permanently stiff, insulin can be lowered, uric acid can be reduced, kidney signaling can normalize. That's why early intervention matters so much. Once vessel damage accumulates, reversal becomes harder, but regulation can still improve. If this video is helping you understand blood pressure at a deeper level, subscribe and stay with it. Because once metabolism is corrected, the final drivers become impossible to ignore. By now, we've uncovered a powerful truth. High blood pressure is rarely caused by one mistake. It's the result of multiple regulatory systems drifting out of balance. But there's a group of people who feel especially frustrated. They eat well, reduce sugar, balance minerals, take medications, follow instructions, and yet their blood pressure remains stubbornly high. In this final part, we'll explain why. Because when blood pressure doesn't respond the way it should, the remaining drivers are almost always hormonal, neurological, or sleep-related. And once these are identified, the mystery disappears. Blood pressure is tightly controlled by your nervous system. specifically the sympathetic nervous system, the fight-or-flight response. When this system is activated, heart rate increases, blood vessels constrict, kidneys retain sodium, blood pressure rises. This response is meant to be temporary, but modern life has turned it into a chronic signal. Common triggers include psychological stress, sleep deprivation, chronic inflammation, pain, overstimulation. When sympathetic tone stays elevated, blood vessels never fully relax. Nighttime blood pressure fails to dip. Medication response weakens. This pattern, called non-dipping hypertension, is associated with higher cardiovascular risk and is widely discussed in autonomic research published through Hypertension. Stress reduction isn't about relaxation trends. Well, it's about turning down hormonal output. Chronic sympathetic activation increases norepinephrine, cortisol, renin, angiotensin, all of which raise blood pressure. This is why interventions that lower sympathetic tone, improve blood pressure variability, reduce nighttime pressure, enhance medication effectiveness. These effects are measurable, physiological, and documented in cardiovascular literature from journals like Circulation. Sleep is not rest, it's regulation. During healthy sleep, blood pressure drops, sympathetic activity decreases, hormones reset, vessels recover elasticity. Sleep deprivation disrupts every one of these processes. Just 1 week of insufficient sleep can raise baseline blood pressure, increase insulin resistance, elevate cortisol, increase salt sensitivity. Even more important is sleep apnea. Undiagnosed obstructive sleep apnea causes repeated oxygen drops, triggers massive sympathetic surges, prevents nighttime blood pressure reduction. Sleep apnea is present in a large percentage of people with resistant hypertension and is heavily discussed in cardiology and sleep medicine consensus statements. If blood pressure spikes in the morning, remains high overnight, resists medication, sleep should always be evaluated. And now we arrive at one of the most underdiagnosed causes of hypertension, primary aldosteronism. Aldosterone is a hormone produced by the adrenal glands. Its job is simple: retain sodium, excrete potassium, increase blood volume. When aldosterone is too high, sodium retention becomes excessive, potassium drops, blood pressure rises persistently. What's shocking is how common this condition is. Studies suggest 8 to 20% of people with resistant hypertension have some degree of aldosterone excess. This is not rare, it's just rarely tested, and salt restriction alone cannot fix it. Diagnosis requires aldosterone to renin ratio testing, proper medication adjustment, endocrine evaluation. When treated correctly, blood pressure often improves dramatically. Potassium normalizes. Medication burden decreases. The kidneys are not passive organs, and they continuously sense blood pressure, sodium levels, hormonal signals. When kidney signaling is disrupted by insulin resistance, aldosterone excess, sympathetic overdrive, chronic inflammation, blood pressure regulation breaks down. This is why early kidney dysfunction raises pressure. Pressure then further damages kidneys. A vicious cycle develops. Breaking this cycle early is critical. Nephrology research published in Journal of the American Society of Nephrology emphasizes that hypertension is often a kidney signaling disorder first and a vascular disease second. It's important to say this clearly. Medication is not a failure. In many cases, medication buys time, prevents damage, protects organs, especially when blood vessels have lost elasticity, structural changes have occurred, genetic factors are present, but medication works best when mineral balance is restored, metabolic drivers are addressed, sleep and stress are optimized, hormonal causes are identified. Lifestyle and medication are not opponents. They are partners. There is a window where blood pressure is most reversible. Before, arteries stiffen permanently, microvascular damage accumulates, kidney injury progresses. That window is often years long, which means early understanding matters. Root cause evaluation matters. One-size-fits-all advice is dangerous. The earlier regulation is restored, the less aggressive treatment needs to be later. Let's summarize what truly controls blood pressure. Minerals regulate vessels and kidneys. Insulin determines sodium retention. Uric acid controls nitric oxide. Potassium balances sodium. Stress and sleep set nervous system tone. Hormones like aldosterone fine-tune volume. Salt only matters within this context. Fix the system, and blood pressure often follows. It's a message, a signal that regulation has drifted. And when you listen to the right signals, not just the loudest advice, the body often responds faster than expected. If this series helped you understand blood pressure differently, subscribe and stay connected, because the goal isn't just lower numbers. It's restoring the systems that keep those numbers stable. For life, stay healthy, and I'll see you in the next video.